on plantar fasciitis. So my objectives are, I'm going to define it, I'm going to discuss the pathomechanics, describe the clinical manifestations/functional limitations, identify the tested measures, discuss the distinguishing characteristics of similar conditions, discuss an overview of the rehab process, the likely outcomes, and summarize. So the terms plantar fascia and plantar aponeurosis are often used interchangeably, although strictly speaking, only the central part of the plantar fascia is extensively aponeurotic. So the plantar fascia is an investing fascial layer of the foot's anterior, also known as plantar aspect of the foot, that originates from the os calcis and inserts through a complex network to the anterior forefoot. It's a tough fibrous layer composed of both collagen and elastin fibers. It serves as a supportive and protective role, and it also involved in weight-bearing function of the foot. Anatomically, the plantar fascia is divided into three major areas, but central, medial, and lateral. But the central portion is considered the major portion. Its attachment site is often involved in a condition called plantar heel pain. In this section, it functions as a dynamic stabilizer. And then the lateral and medial portions, these are smaller and thinner and cover the undersurface of the abductor digiti, minimi, and abductor hallucis muscles. Also, and it talked about the windlass. So this is a mechanism involved in passive lifting of the medial longitudinal arch. The plantar fascia serves as the cable for this mechanism by wrapping around the metatarsal heads. And then it talked about the tris, I think that's how you pronounce it. In the foot, there's a system in which the triangular unit, that is the medial longitudinal arch, with the ankle joint functioning as the apex of the triangle. The calcaneus and talus are the posterior struts, and the first ray is the anterior strut. And the role of this with the plantar fasciitis is stabilizes the two by limiting the ability of them to spread apart. So for the condition, pain is usually experienced along the plantar aspect of the foot, where the plantar fascia inserts on the medial tubercle of the calcaneus. This site is typically tender to palpation. The pain occurs on initial weight bearing after periods of rest, and then it can decrease, but it returns as weight bearing activity increases. And its associated impairments include hypomobile, gastroc, soleus complex, and the plantar fascia pain or restriction when extending the toes. So some of the causes, so it's no real known cause, it's just a gradual condition. It's highly irritable the first few steps upon walking and or after periods of rest. Pain eases with increased walking but returns with prolonged standing. It's a random onset. It typically is not a result of an injury or trauma. The calf and Achilles complex most likely will be tight with poor soft tissue quality. This can lead to a loss of dorsiflexion and the amount of foot pronation during gait. And this may cause a decreased mobility in the plantar fascia. And the high body mass index and inappropriate footwear. So some clinical manifestations, pain with repetitive activity on palpation of the involved site, with stretch. Pain is muscle length and strength imbalances, abnormal foot posture, weight bearing, especially with the first thing in the morning, and tenderness on the plantar aspect of the heel. And then functional limitations can be difficulty, weight bearing, decreased standing tolerance, and decreased speed and distance of ambulation. So for the test and measures, you can do active range of motion. This is going to be full and pain-free. And then with passive range of motion, this is going to be pain with overpressure into the great toe extension. And then for the observation, it's going to be unremarkable with flattened arches and a pronated foot. And then you can do the windlass test, which is a plantar fascia test. It's performed by forcibly dorsiflexing the first metatarsal joint to elicit the traction-induced plantar heel pain. So some differential diagnosis. I'm not going to go into detail on all of these. You can find it on page 1052 through 1053. But the gastroc strain is a mechanism of injury. It's sudden overload, and symptoms are aggravated by heel raise, Achilles, tendonitis. The mechanism of injury is overuse and pain on the posterior ankle. Morton's could be closely related to plantar fasciitis, but the difference is there would be a tenderness upon palpation in the wet spaces of the toes. And yeah. So the rehab process. So for the maximum protection phase, if signs of local inflammation are present, you'll treat it as an acute condition with just rest and appropriate modalities. Stress relief can be achieved by immobilization in a cast or orthosis of the foot with it slightly plantar flexed, or a temporary heel lift, a shoe orthotic, or some taping. But some interventions that you could do is just a deep massage, roll the foot on a ball or a bottle. You'll do a passive stretch. For the active range of motion in pain-free range, you can do alphabet writing, toe curls, active arch raise, like towel scrunches, and ankle control on a rocker or a walking board. So for the moderate, when symptoms become subacute, the entire lower extremity as well as the foot should be examined or impaired alignment. So you can do a plantar fascia stretch, you can do some calf raises, dynamic warm-ups such as some marches, open kinetic chain, thigh and hip strengthening, and then some exercises can also include concentric exercises with tubing into dorsiflexion, plantar flexion, inversion, and eversion. And then for the minimal protection phase, just continue with the patient education and progress to all those activities before, and then you would just increase the repetitions and speed of the movement. So some likely outcomes, just decrease the pain and inflammation and swelling. You want to protect the area from re-injury, reestablish pain-free range of motion, prevent muscle atrophy, increase weight-bearing tolerance, increase neuromuscular control, restore normal joint kinematics, attain full pain-free range of motion, improve neuromuscular control of the lower extremity and weight bearing for both level and uneven surfaces, improve strength and endurance, and return to the previous level of function. So for an overview, plantar fasciitis is inflammation of the plantar fascia within the foot, which results in pain on the sole of the foot. It is gradual and has an unknown cause. Functional limitations include difficulty standing, decreased speed, and difficulty weight bearing, and rehab can include strengthening of the hip, knee, and ankle. These are my references. Any questions?
Go to your, go back to your clinical manifestations slide. So you see the bearing, especially the first thing in the morning. So that's specific hallmark to plantar fasciitis. So most of your patients want to say, when I get out of bed, when I get up first thing in the morning, it's excruciating when I stand on my feet. And so that's a hallmark to plantar fasciitis. So you want to highlight that item. Now go to your rehabilitation overview. Rehabilitation can include strengthening of the hip, knee, and ankle. So what does that mean? If someone comes with plantar fasciitis, what do you need to be assessing? Yeah, the entire kinetic chain. I would start with the hip, because the hip is going to be instrumental, is going to play a key role in deficits that could be likely working its way down the lower extremity kinetic chain, which could be the ultimate cause of plantar fasciitis. See, and then also looking at muscle imbalances, like tight hamstrings, are a hallmark cause of plantar fasciitis as well. So you increase the extensibility of the hamstrings, can likely resolve, if someone has tight hamstrings, can likely resolve plantar fasciitis. That could be the culprit. But you just want to do an in-depth examination. It could be a tight iliopsoas causing it. So you never know, but you gotta go look. You gotta go look at the hip